Welcome to Healthcare Upside Down with your host, Dr. Nick Vanterhaven, and brought to you by ECG Management Consultants. You can learn more about the show on the program's page at healthcarenowradio.com or on our blog at ecgmc.com/HUD. The U.S. spends more on healthcare per capita than any other country on the planet. So why don't we have superior outcomes? Why haven't the principles of capitalism prevailed? And why do American consumers have so much trouble accessing and paying for healthcare? Each week, Healthcare Upside Down will dive into these and other issues with ECG principal Dr. Nick and guest panelists as they discuss the upsides and downsides of healthcare in the US and how to make the system work for everyone. And we end with your better pill to swallow, the conclusion to today's episode with insights on challenges and changes that improve healthcare. Now here's your host, Dr. Nick.
For most of the United States, Thanksgiving is a time to get together with family and friends, relax and unwind as we celebrate the passing year and all that we have to be grateful for. It remains one of my favorite traditions, a new addition to our family that is a first-generation immigrant to this country. In fact, when we first arrived, we had no idea what this holiday was, even that it was a holiday. Our first celebration was something of a bust, a regular day that I drove to work, wondering why there was no traffic making the drive from Connecticut to the Upper East Side of Manhattan in record time. Parking was a breeze too. When I arrived at the hospital, Mount Sinai in New York, there was some staff around, but it was a skeleton crew, and I quickly discovered this was an official holiday, and I drove back home to let the family know. But for radiologists in the United States, and anyone working in that sector, Thanksgiving oftentimes finds them away from home, attending one of the largest gatherings in radiology in the world, RSNA, or the Radiological Society of North America. It's always the same time each year, immediately following Thanksgiving, and puts a strain on flights, hotels, and infrastructure for Chicago every year. It is world-renowned as a meeting place and an opportunity to get the latest and greatest updates in radiology from science and technology. The halls at McCormick Center are lit up with amazing displays of innovation and technical progress as the vendors in the space show off their latest developments. Like all these types of events, it's full of glitz and glamour designed to attract interest and attention. The progress is amazing, but can come at a steep cost, with some eye-watering prices for the latest in imaging technology. The pandemic had an impact, limiting the show and attendees during the peaks of the pandemic, and like many of these events, people are thronging back, glad to attend and reconnect with old friends and colleagues. But attendance is now coming in the shadow of the pandemic experience that shone a spotlight on our system that's failing so many and in some fundamentally inequitable ways. In the context of these challenges, attendees are questioning the value of these advancements and if the investment is worthwhile. Is the juice worth the squeeze, as some would say? This is especially true for many coming to this event from poorer, less well-served communities with limited resources and a very small checkbook, if one at all. Join me on the Healthcare Upside Down show as I talk with Professor Richard Duszak. He's the professor and chair in the Department of Radiology at the University of Mississippi Medical Center. Hi, Rich. Welcome to the show.
Nick, thanks for having me here. It's great to reconnect. I'm looking forward to it.
So you've recently moved to a new role, new opportunity, and just come back from RSNA, which is, one of the primary radiological shows where we see the latest and greatest innovations. But one of the things that sort of strikes me about that is that, well, that's all well and good, but how does that reconcile with the environment that you live in, which I think struggles a little bit with service, right?
Absolutely. So, just a little context for that, Nick, is I've gone through a little bit of a somewhat, some people would say diverse career, some people would say serpentine career, but spent my first 18 years in private practice. And in those roles have served sort of smaller cities, but also areas where there's been a regional, rural, underserved population as well. Spent the last 9 years before coming here at Emory University, one of the biggest radiology departments in the country. Lots of high tech. I mean, we pretty much had the new sexy whatever it is. And now chair of the department at the only academic medical center, primary safety net hospital in the poorest state in the country, the one with the shortest life expectancy in the whole country. And so as I was at RSNA this year, to your question, really reflecting upon how my perspectives of that meeting, what I was looking for, what I was prioritizing have changed a lot over time. And, particularly at a high-powered academic place at Emory, I was there for a lot of the science. I was there to look at the new, sexy, whatever it is, machine. And now, I'm in a department where our backlog to get in for things like CT for PET is about 4 weeks. We are very, very capital constrained in this environment. And so it was really a fascinating visit for me from a point of view of my conversations, particularly with the vendors, but also with colleagues elsewhere, that people at RSNA, like a lot of cutting edge meetings, are always talking about, really pushing the envelope. Let's take a scanner that's got 92% specificity or sensitivity, and let's push it to 94%. Look, this is so much better. And of course, when you ask the vendor, well, ballpark, what's the price? It's, the current one's about $2 million. The new one's going to be about $3 million, but aren't those extra lives worth it? And the piece here where I'm now looking at this is like $3 million is a huge, huge ticket for a center. And if I could get just 3 plain old sort of Ford Explorer non-Maserati scanners for $1 million each, that would be so many Mississippians who don't have access to imaging that I'd be able to serve. So my perspective, and I'm still trying to synthesize my role here and the needs of this state, was very different than any time I've been at that meeting. And I think for me, it was really my wake-up call from a point of view of now, I'm living healthcare inequities and disparities and need to figure out how to be part of the solution rather than part of the problem.
So you talk about the waiting time. That's essentially one of the rationing components of care, whether it's in a pay or fee for service type experience. It's also true in the NHS, which is the original system that I came from. I just had discussions with friends in that system, and that's exactly what's going on. They have rationing of care, which is their methodology to sort of deliver care within the boundaries of the economic availability. You're saying you've got this wait time. Is it just about the technology? What about the people? Do you have enough radiologists? It's not just one thing in this particular instance. What's contributing to that inability to deliver sufficient resources to satisfy the population that you've got?
Yeah, you're absolutely right, Nick. This is not entirely a capital piece, although that was, the piece that's in your face there at RSNA. It really is multifactorial, is that, when you are in the poorest state, we, like a lot of other more rural areas, will have a lot of brain drain. A lot of our graduates, a lot of, whether they're medical or non-medical, will leave to go to greener pastures elsewhere. We've had to train a lot of our own people. So a lot of the efforts are, do we have enough technologists? How separately, working with our rad tech program here, how do we start building the farm team here so that we have a pipeline? And additionally for radiologists as well, how do I, as the department chair, make this job as attractive as possible? How do I work with our leadership to make our salaries as competitive? And also, get people to at least take a look. We love, my wife and I love living in the Jackson suburbs. It's one of the nicest places we live. But I think the knee-jerk reaction, whether you pick Mississippi, you pick, one of the so-called flyover states, you pick West Virginia, is, oh, it's a bunch of people with no teeth and no shoes. And, yes, there is a lot of poverty, but there also are some really great communities. And so one of the challenges is to, get people to see the potential that we have here. And it really is hard because it's multifactorial. The capital, as you indicate, will not solve it. The scanners, at least until AI gets off a little bit better, will not scan the patients themselves. We need the radiologist to interpret the images. So it is a bunch of pieces. And I think it is really the cycle of being in, a really rural area, which is about 15% of the US population and a lot of our geographic landmass.
So as you think about this, obviously you're fresh back from RSNA. It sounds like even though you've had this serpentine career that's navigated to this, porous state, struggling to deliver the healthcare that the people need, what was the response from the people that you were interacting with? Did they have answers? Did they have actual thoughts around how this might be approached? Because ultimately this is all of our problem. We can't all continue on this trajectory.
It was fascinating, wandering through, and probably the first time you and I met 15 or more years ago was at one of those random booths there when you were working with, one of your former lives. I think the standard answer from the more salespeople is, when you ask the question of, do you have something cheaper? It was sort of this look of, what are you talking about? People don't come to RSNA to ask those questions. They're in the Maserati, the Porsche showroom here, and you're asking for a Ford F-150 pickup here or a Ford Explorer utility vehicle here. So I think that was the most common piece there. Although, I did participate in a couple panel discussions talking about access, and I think the overall milieu, if it will, of understanding of disparities, the awareness has raised a lot over, certainly the 30 years of my career in radiology. I think people are aware that there are disparities. I think the traditional knee-jerk reaction is a lot of those are, much more along racial, ethnic lines, reminding people about rural, and, we've got a convergence of a number of them here. Is out there. So I think there is an awareness of, aha, I must admit, and I won't call out because hopefully other folks will come on board, but had some really great discussions with some leadership of one of the big vendors that heard some of my comments and said, we're involved in a lot of global health initiatives, and a lot of the things that we're talking about doing in underserved countries, we probably need to be thinking about, doing domestically here. So I'm trying to work with one of them to arrange for a site visit to just, rethink their business model, because I think for a diversified portfolio for the big for-profits is, they're not going to sell the $3 million whatever it is in a lot of places, but they may sell multiple smaller ones and be able to, expand their portfolio of services. So overall, it was a quite mixed reaction, but, I look at when you move to a place like this and you say, I want to bring about change, this is a marathon, it's not a sprint.
Yeah, so I think it's heartening to hear that there was at least some positive response. Obviously, no surprise to hear there's pushback. This is what we're selling. You should be excited about this. This is the gizmo experience. People want to sort of show off their best. But ultimately, what you're experiencing is not unique, I don't think, to Mississippi. I think it's relatively widespread, and you described some other states, but I think it's broader than that. There's certainly some focuses of places that have experience and have money, resources, lots of people, but the rural community is the focal point in many instances, and the struggle is real. When you think about that from your perspective, you've landed in this, you've moved, you're living it each and every day. How do you get up every morning, and what do you think about? What is your sort of focal point to say, how do I solve this? Because this must be a huge pressure on you.
It certainly is, and I'm really privileged to be part of a really great leadership team here at the University of Mississippi Medical Center, and certainly there's great leadership teams elsewhere where this really is our core mission. I mean, it is our vision to say, how do we improve the lives of Mississippians? And so I think a few pieces of advice, and I remember when I was in the final stages of being recruited here, our dean and vice chancellor, Dr. Luann Woodward, who's been just a great supporter, said one of the hardest things you will have to do at a place like this is decide what to say no to, because there are so many demands placed upon us. So it really is prioritizing. It's, it is, I quote a lot of times in meetings, the aphorism of, necessity is the mother of invention. How can we be creative about solutions? And so even some of the things when, going back some 20 years when I was president of a private group where, some of my fiduciary responsibility back to the group was, how do we maximize our profits? How do we improve our efficiency? A lot of those same tools, I'm going back and trying to use those, not so much from a point of view of a for-profit practice, but from a point of view of how do we expand access. So it's really trying to cherish the baby steps every day. I mean, I think if you keep looking at sort of the Grand Canyon we need to cross, it's daunting and it's frustrating. And celebrate the little wins. We improve the efficiency of this protocol, and guess what? We can get one additional MR patient into each of our 9 scanners every day. That's 50 Mississippians a week that are getting an MR that they weren't getting before. So I think a lot of it is just having the positive attitude that we will get there. We're not going to fix this overnight. I do keep the blinders on a little bit, because I think if I focus too much on the big picture, it probably will depress me.
Yeah, I think that's fair comment. And, over the course of time that I've known you and, many radiologists, you've always been, in my mind, at the bleeding edge in terms of technology. It's that innovation, we've improved things, as I look back over the technology and where we've gotten to, that's obviously contributed, I think, to improvements in healthcare. You're thinking about this slightly differently, but you did sort of intimate that there's components of this that might help because it's a resource issue. Is the technology that you see that's going to help, or is that really sort of a minor player in your view now?
Yeah, I think a lot of this is, invoking that R word that you use, the rationing. And while, nobody says they want to ration, the reality is if there is not thoughtful, policy-oriented rationing, the market will ration in ways that we don't like and only enhance disparities that are out there. So, I think there's got to be an awareness of that. I graduated medical school in 1989 and has watched radiology, as you said, being at the bleeding edge. And, one of the reasons that I'm so excited about, when I meet with medical students who are interested in radiology, has just been telling them about that amazing journey that we've just pushed technology. I mean, we in radiology have changed the way that medicine is practiced in the United States. And certainly a lot of other specialties have done that as well. But I think we need to pivot our perspectives. I mean, I think, that historically the question has been, can we do this? And the reality is, sure, we can do it. We can, increase the number, the speed of our scanners, our computer processing, or artificial intelligence, our integration. But I think we need to have some really hard conversations about, should we be doing these things? What is the best use of these resources that are out there? And, by pushing the technological envelope too fast, and I certainly want to make it clear, I'm not anti-technology, I'm not anti-progress, but I think this has got to be balanced, it's got to be thoughtful, because in a resource-constrained world in which, a lot of this is a zero-sum game, to improve the quality of the scanning or the imaging, that you or I, as physicians with resources, may be able to get because of our privilege, that comes at a cost of some other people not being able to get to it. And, what is good enough? And so I think those are the questions that we as physicians have traditionally not been trained, educated, or has to think about, nor has it been a priority for us. I think a lot of people are like, your job as a physician is to look after your individual patient. And in the short term, yes, but in the reality, that's just not a sustainable model for us if we really say there's lots of people in our population who need care.
So I think important points, within all of that go back to the issue of how we allocate our time and resource, time being the most valuable component of all of this. And, obviously you're in this setting that is a struggle to attract people. I think radiology did a pretty good job of the remote working. Has that been a contributor in terms of helping you to fulfill the needs of your population?
Remote has been something that we definitely are embracing here. I mean, I've seen, remote in radiology being a huge asset and attribute, and being able to help us as a national workforce be much more nimble. That being said, I've seen the push to being remote, however, having a lot of downsides, because it's, I can sit in my basement in my pajamas and interpret scans, but there's never the conversation, the real-time interaction with the technologist, the real-time interaction with the referring physician, the participation in tumor boards. And yes, you can do a lot of that virtually, but it doesn't have the richness. It doesn't have the collaborative, catalytic ability of doing those things in person. Certainly from a point of view of us being market competitive to be able to recruit, we are allowing most of our physicians to work from home about a day a week. Our overnight folks are essentially working from home completely. We're even exploring some models for non-physicians as well, talking with some of the vendors about, remote control, if you will, of scanners, that we may be able to put some of our most experienced people in sort of a, control room, and have newer people on the front lines, doing some of the scanning, but have immediate backup to jump in. We're exploring such a model for some of our medical physics and things like that as well. And a lot of these conversations get into even, our meetings with our telehealth group here, which is one of the biggest in the country, from a point of view of, can we expand telehealth beyond simply physician services, and start looking at, is there a way that we can put a rad tech right out of school into a very rural hospital to get the patient on and off of the scanner, but yet have an experienced CT tech here, essentially running that scanner at the higher level there. So again, I think it's some of the necessity, begets innovation piece, but I think there's a lot of opportunities in remote, but you've got to work through the infrastructure, you've got to have the vision, and you've got to have the IT support to do it.
Yeah, so I within all of that, I think celebrating the small successes, the improvement, focusing down, important, relevant issue there is, what is good enough in the circumstances, with the available resources that you've clearly done. I think tremendous opportunity with technology that can improve, but not at the cost of reducing services, that I think you're finding a constant balance. Obviously a huge task ahead of you, tremendous amount of respect, and, very grateful for you sharing some of those insights. Rich, thanks for joining me today.
Nick, it's been great reconnecting, and I certainly appreciate the opportunity to tell our story and just get it out there.
Investment decisions are difficult, and no matter what facility or role you work in, resources are limited. We need to expand access and serve the whole population equally. As you heard Rich say, we have to have hard conversations and ask ourselves and our colleagues, should we be doing these things? Is that the best use of the limited resources we have in our resource-constrained world? Is that the next best use of the available dollar in our wallet? Your better pill to swallow is to learn to say no. No to projects. No to investments. No to anything that is not serving the patient in the delivery of fair, equitable, and compassionate healthcare. Thanks for joining me, your host, Dr. Nick, on this week's edition of Healthcare Upside Down. Until next week, keep solving the business of healthcare, as if your life depended on it, as one day soon, it will.
That's all the time we have for today. You can find all of our episodes on your favorite listening platform by searching for Healthcare Now Radio. Also, check out our blog at ecgmc.com/HUD for summaries and commentary from each episode. Follow our show's social hashtag, HCUpsideDown. And join us each week as we work to solve the business of healthcare for everyone.